I should say, I guess it's good afternoon now. It's 12 o'clock. Welcome, everybody. And it's really my pleasure to kind of set the stage for Dr. Chapin, who'll speak after me, about the ME panel, and thinking about why a syndromic approach is really the way that we need to think about addressing meningitis and encephalitis. And of course, the diagnosis is one of the key things, but it's also really key for us guiding really rapid and appropriate antimicrobial therapy to really improve patient outcomes. So we all know that this is probably one of the most critical diagnoses that we make. The patient comes into the emergency room, and so we really have to quickly balance what's going to be the best for that in order to really manage the disease effectively. We also know that with meningitis and encephalitis, probably more so other than maybe sepsis, we're really under the gun for a really short time span in which we want to get it right. So most of the time we end up treating everybody empirically, broad spectrum antibiotics, because of the clinical outcome is so severe that we certainly don't want to take that chance. And in the US alone, there's probably it's estimated about 3,000, it's probably a little bit more, deaths occur annually because of inappropriately or not treated accurately and as fast as we need to in cases of meningitis and encephalitis. So the goal really is to decrease morbidity and mortality, whether it's a bacterial infection, a viral, or either fungal. They all have very serious sequelae to varying degrees, whether it be permanent brain damage or nerve damage, complete neurological changes that may or may not be permanent, seizures, lack of muscle control, things like hydrocephalus. It can even end up with blindness and optic atrophy. So there's a whole gamut of the sequelae relating to these types of infections. And one of the critical things about this is that sometimes someone can present very clinically in a very specific way that you pretty much know right off the bat what they have. But also with a number of these infections, the clinical symptoms can also overlap. And so we're thinking about multiple different courses with a lot of different factors that we take into play in making that initial diagnosis. So what I'd like to do, just to kind of set the stage, I'm going to present 5 cases. These are cases that I had in my hospital when I was still on clinical service there, and just kind of illustrate the different scenarios that we tend to see on a regular basis. So this is a 23-year-old male, a 23-day-old male, excuse me. He comes to the emergency department. His parents noted he had a fever, he was fussy, he had failure to nurse, and they said he had this little bit of like a little reddish diaper rash. They thought he had a possible seizure at home. They weren't sure, but the baby was lethargic. He was not responsive. His history, he had had a normal vaginal delivery, good APGAR. Mom was discharged 2 days after delivery. There was no one sick in the household. There were no sick contacts. And the baby basically had been home since birth. The baby was very ill looking. He had a temp of 40.1. He had 243 white cells, a glucose of 85, a protein of 112. On gram stain, numerous WBCs were seen, 85% lymphocytic and 15% polys. So now we're thinking about this child, and here we have a newborn, basically neonatal infection. So these are the common things that we think of. So we're thinking of things like E. coli, group E strep, listeria, Haemophilus influenza in the very young babies. We sporadically see those cases because they haven't gotten their Hib shots yet. Of course, herpes simplex 1 and 2, and depending a little bit on the seasonality, we start to things like enterovirus and parvovirus. Now this baby was really sick, so it really pointed us in one direction. We did a T1 weighted MR, and you can see here this extensive hemorrhagic infarction of the white matter and the cortex. And of course, a PCR was done on the spinal fluid. We had quickly identified that as a case of herpes simplex type 1. A couple of days later, when these pictures were taken, the diaper rash turned out to be herpetic pustules that formed on the baby's scrotum and in the anal area. And unfortunately, this is the baby's scan 1 month later showing complete cerebral atrophy. Okay, case 2. So now we're getting a little bit older here. So this is a 3-year-old female. This is the month of August, comes to the ED with fever, vomiting, rash, and irritability. Parents say the symptoms developed rapidly and persisted over several hours. Otherwise, perfectly normal, healthy 3-year-old, active. It's the summer, and she attends a swim for fun daycare with her older sibling. Mom reports a slight fever for 2 days. The older sibling had had a fever and mild diarrhea for 1 day, but other than that was now healthy. Not very ill looking, temp 38, slight nuncal rigidity, a little light rash. CBCs were normal, CSF 15 white cells, glucose 85, protein 85, gram stain, few WBCs, 90% lymphocytes, 10% polys, and no bacteria seen on the gram stain. So now we're going to get into this little bit older age group. So we're thinking of things like strep pneumo, of course, Neisseria meningitidis, non-typable H flus, the summer enteroviruses par echo, could be primary HHV6, could be primary EBV or CMV. And of course, now, particularly in the summer months, we add on things like maybe arboviral infections. Okay, so this story has quite a bit of different ending, of course, than the first baby that we had, because this is a typical positive summer enteroviral infection. And what we were doing in our institutions is when they would come in, they don't look very sick. It looks like a typical summer viral meningitis. If the EV or the parvovirus is positive, they're held for 18 to 24 hours in the DD in what we call a short stay unit. And if everything is negative the next morning, the cultures are negative, 24 bloods are negative, we simply DC the antibiotics and we discharge the children. So in this case, it really makes a huge impact, that rapid diagnosis, rather than waiting 72 hours on IV antibiotics for all the cultures to be negative. And there's been a lot of studies that have taken a look at this as one example of the rapid impact of doing enteroviral PCR in the time was able to decrease the time to discharge. They received less CT or MRI scans, less chest or abdominal x-rays, less EEGs, and of course less intravenous antibiotics, which is really key in antibiotic stewardship. Okay, so now we have an 18-year-old female, sudden onset of fever, nausea, vomiting, headache, persisted for about 24 hours. She was non-responsive to waking the next morning. So her parents called 911. They thought she may have had a seizure. History, she was otherwise healthy. She recently started college. She was home for the weekend. She lives on a dorm on campus. She has no drug use. She denied any recent sexual history, and she was up to date for all her immunizations. She was very ill-looking. She was non-responsive. She had a temp of 40.1, a petechial rash, pulse 104, respirations 24. Her blood pressure, she's hypotensive, 88/34. They immediately start her on an antibiotic. They rush her for a CT scan, and then 5 hours later, they're then able to do the TAP. There's no organism seen, 900 white cells, 95% polys, 85% monocytes, protein 123, and a glucose of 23. Now, of course, we have a really good idea based upon her symptoms, how severe the illness is, the petechial rash. But one of the things that a lot of times we have to deal with, and this is in the IDSA guidelines for suspicion of bacterial meningitis. And what happens in these cases where patients come in and they've had a seizure is that they draw blood culture stat, they're started on dexamethasone and antimicrobial therapy, but they're immediately sent for a CT scan. And a lot of times that really delays the time in which they can do the lumbar puncture. So now these patients have been pre-treated. And some of the pathogens in the CSF within 1 hour the gram stains can be negative, they can be cleared, even though the disease has such a major impact. So of course, in this case, with this girl, 3 days, her blood and CSF cultures were all negative, but her CSF PCR was positive for Neisseria meningitidis. Okay, now we have a 49-year-old male. He has fever, vomiting, headache, persisted for 3 days. He's seen in the ED due to increasing severity and persistent headache. Otherwise healthy, no past significant medical history, no sick household contacts. moderately ill, a little bit of a temp, no nuchal rigidity, no photophobia, no rash. Most of his signs were pretty normal. His blood pressure was stable. CSF, no organism seen. He only has 10 cells, 95% lymphocytes, protein 85, glucose 72. CT scan is negative. So what they did is they gave him Tylenol. They discharged him from the ED with a diagnosis of a viral-like syndrome. You know, that catch-all for everything that nobody can diagnose. Okay, so here's our patient down here. Now we're thinking about some other things, of course, strep pneumo, Neisseria, Mophilus. We get into some of the other gram negatives, things like Kingerle Kingae, HSV 1 and 2, varicella, EV, and then, of course, this summer, you can think of arboviruses. I put neuroborreliosis. I live on Long Island, and we have tons of Lyme disease. So you think about other things along this way. So this is what happens to this person because he was not tested appropriately the first time he came to the ED. They did do a spinal tap, but they didn't send any testing. So he worsens. He returns to the ED 2 days later with severe worsening headache, complaining of severe pain over his left eye, decreased visual acuity, ophthalmic examination. He was simply given steroids, and he was sent home again. 3 days later, he comes back to the ED, and this is what he has. Okay? So he has classical zoster. And when we went back and tested the spinal fluid that was corrected on day 1, his spinal fluid was positive for varicella zoster. You see commonly that transient meningitis prior to zoster. He would have been treated 5 days earlier and probably would not have ended up like this with the risk of losing his eyesight. So really a critical diagnosis, something that people weren't thinking about at that time. Okay, so our last case here, 33-year-old male, ED focal limb weakness, symptoms of a headache, stiff neck, growing progressively worse over a week. History, significant weight loss over 18 months, intermittent fevers, exhaustion, anorexia. He's had oral thrush, he's had a history of syphilis, LGV, and then he finally admitted unprotected sex with men. Okay, so he was partially non-responsive. Growing up in the AIDS epidemic in New York, he had what we call the look, classical, undiagnosed primary HIV, AIDS, temp, pulse 80, respiration 16, he's hypertensive. They do a lumbar puncture, his opening pressure is 360, white count 40, glucose 49, protein 105, gram stain, moderate WBCs, no bacteria seen. Of course, they order India ink, it's the middle of the night, the stat labs don't do India ink, and very unusual, his cryptococcal antigen, which they do staph from both the CSF and from the serum, are both negative. Okay, so now we're thinking about this patient population. We're thinking of someone that comes in who's severely immunocompromised. So all of the above they could certainly have, but then we start thinking things like Listeria, CMV, EBV, HIV, HHV6, of course, fungal infections, any kind of gram negatives or whatever, toxo, cryptococcosis. And so what you can see here in the course of all of these different brackets, the pathogens that are in red are what's covered by the meningitis encephalitis panel. And of course, this was his scan. You can see this whopping lesion here in his brain. This is his India ink with numerous encapsulated yeast cells. And you can imagine, we see it on the India ink, how much is in his spinal fluid. And then, of course, this is his positive HIV-1 test that was done stat in the emergency room. Now, we dealt with HIV and AIDS for 25, 30 years in New York. This is a classical presentation of cryptococcal meningitis in an undiagnosed HIV. But the key thing is here, if people aren't really aware of this and used to dealing with this, there's this phenomenon that we've seen where this was a paper that said delayed diagnosis of cryptococcal meningoencephalitis due to a negative cryptococcal antigen test. And in the 25 years doing HIV, I've seen 3 cases of patients that had fulminant cryptococcal, blood, spinal fluid, and had both negative cryptococcal antigen in blood and CSF. It's not a prozone. They have something about their capsule that's not recognized, and you gotta also be careful, some of the tests don't recognize Gadii. So this again here was really a critical diagnosis that the PCR would have quickly identified if there was any doubt as to the diagnosis. So why a syndromic approach? We have overlapping symptoms with different treatments and outcomes. We have poor sensitivity of our conventional tests, negative results due to pretreatment, delayed results with traditional or if you reflex testing or you have to send the testing out, identify causes they may not be considered in the original diagnosis, and delayed appropriate therapy. And finally, sometimes just confusing results. So really, by approaching it syndromically, we make a diagnosis, we allow rapid and appropriate treatment, initiating infection control measures, particularly with things like meningococcus, rapid discharge in the cases of our viral enteroviral patients, and DC inappropriate antiviral or antibiotics, and that's certainly important for stewardship. So I'm going to stop there now, and I'd be happy to introduce Dr. Kim Chapin, who will present next.
Okay, so good afternoon. I was asked to do this presentation because we were one of the many sites that was involved in the FDA clinical trial. So I am going to repeat a few things that Christine already mentioned, basically because they need repeating for emphasis. These are my disclosures. Basically, I'll try out any new toy that comes along. So I'm going to talk a little bit about epidemiology, meningitis, encephalitis, current diagnostic procedures, and why they don't particularly work well for us, and really focus on the FDA clinical trial data. And then I just have literally 3 cases that happened in the last week where this panel would have really been helpful, and then I just got another call this morning on another case. So itis basically is inflammation, and in this case of the brain of the meningeal tissue surrounding the brain, about 15% can be fatal, and a large percentage with serious sequelae. A broad range of symptoms, which is exactly what we've seen with respiratory disease, GI disease, now meningitis disease. It's very hard to make a specific diagnosis. And I really don't know how many diagnoses are we missing. No one really knows that. Maybe 30%, maybe 70%, really don't know. And as these syndromic panels become more used, we're learning more about the pathogenesis of these diseases. So really what a lot of us do is we do the clinical approach ruling out the most common things first. So almost everybody gets a bacterial and an enterovirus and HSV test. That's kind of up front. Why? Because most of us have made a lab-developed test. If you aren't using one that's now currently FDA cleared, there is an EVS FDA cleared test, and bacterial stuff culture we're good at in the microlab. We've been doing that for years. But really, depending on the patient's history and the time of year, the results from other lab tests, and critically, how much spinal fluid might be left, we then cast the net very broadly because, as Christine pointed out, the sequelae are very serious. And so we want to try and figure out exactly what's going on. Again, because later down the line, we can tell the patient or parents what are your likely sequelae, what to look at, what's your follow-up going to be. The outcome, though, is delay in diagnosis or no diagnosis, over-treatment, definitely, excessive testing, like beyond ridiculous, and potentially another lumbar puncture. So what do we do now? I actually added on the one side the pathogens and actually the amount of CSF that's required to do the testing. So for bacteria, yeast, viral, or AFB-based tests, we really need like up to 10 mLs. So if you want AFB diagnosis, we gotta have 10 mLs. Well, good luck getting 10 mLs of spinal fluid. The average turnaround time for just a gram stain is about an hour, but unfortunately, it's not specific. It's subject to performance variation. It is my biggest albatross in the laboratory that I cannot keep up with the inability of technologists to read a gram stain appropriately on first, second, and third shift. And I have some examples of that later. Bacteria and yeast take anywhere from 1 to 3 days. You're usually waiting for growth and susceptibilities. Cryptococcal antigen is great if you can get it done rapidly. You might be able to see it on a gram stain, but as Christine pointed out, in HIV-positive patients that haven't been treated, their capsule sometimes isn't there, so the yeast doesn't look like a cryptococcus, or it doesn't react with the antigen test. For PCRs, the variability of what we can find and how fast we can find it varies incredibly, so I can do an EV test in 4 hours, and that's shorter than the time period that a patient might be in the ER, so that's the critical time point for turnaround. HSV 1 and 2, it takes us much longer, and if it's a weekend, you gotta get a special request to get it done. If we got to send it out, it can take up to 3 days. So the turnaround time is highly variable. If you're going to send the tests out, you may need 1 to 2 mLs per test, because that's what the reference lab wants. So not very user-friendly. And this is just a picture of how we get a spinal tap. If you haven't been fortunate enough to go through this procedure, you end up having basically a sterile procedure done. You feel for where you're going to stick the spinal needle in, and it literally is, you wait for one give through the dura and then wait for the next give. It's a very painful procedure, and sorry, this is a fuzzy picture, but basically the needle is as long as a pencil. So how many people want to volunteer to get that done? Not me, thank you. And sorry, this is also fuzzy as well. Just to go on the meningitis, encephalitis panel and what's on it. This is a very nice, cute little baby, and it's a picture off the internet that didn't project well. And it's got 15 different signs and symptoms you're supposed to look for in a baby to figure out what they have. Good luck with that. And then the other picture is actually of a meningococcal meningitis patient. Okay, so these are the 14 pathogens that got cleared on the panel. So we have a number of bacteria, viruses, and yeast, Cryptococcus neoformans and Gattii. These are the major pathogens that we would want to consider. As Christine pointed out, during the summer, we're looking at arboviruses and certainly some other pathogens. So some of those things are not on this panel, but this is really the brunt of what we would see. The key thing here, and this is really important, more for physicians than it is people in the lab, is that these panels are not do it, take an answer, and go with it. It really is in the context of the clinical presentation. So I joke and say MD stands for mentally deficient, and I can say that because I'm one of them. But essentially, I got 3 emails this morning about a single organism, and what does this mean? I'm like, well, is the patient sick? You have to ask all these questions. So because of how the FDA actually looked at this assay and looked at some of the pathogens that was on it, including HHV6, HIV, EBV to start, you have to look at the clinical, epidemiological, and laboratory data in order to put everything together. The other key thing is you cannot use this test to detect the pathogens normally associated with CSF shunt infections, which is typically coag-negative staph and propionibacterium. So for all those who have just converted to an electronic medical record where for some reason your site and source don't work, it's actually really important to know whether you've got a shunt specimen or actually a lumbar puncture. So, okay. So what are the specimen requirements? The key thing is you basically need 200 microliters. That's a godsend in spinal fluid analysis. You do not centrifuge the specimen. So there's actually a technical reason for that, in that if you centrifuge and use the pellet, which some labs do for bacterial culture, you may actually be missing some of what you're really looking for if you use just that pellet, because it's in the supernatant, such as viruses. So you don't use a centrifuge specimen, you use it straight. It's best to test the sample as soon as you get it, but you can leave it for room temp for up to a day, but 7 days refrigerated. Really what was impressive during this clinical trial was that no matter what the specimen looked like and how many cells were in it, you basically had no interference issues. And why is that key? Because right now my EV test, I have to freeze the specimen for 10 minutes at -70 before I can test it, because I was getting 25% inhibition with my assay. So we do that extra 10 minutes because the inhibition has gone down to 5%. So this is actually a really critical issue as well. If you run the test, you want to make sure that you can report the result. So I'm going to talk a little bit about the analytical validation, limit of detection, reactivity, inclusivity, precision reproducibility, and then the clinical validation, which was a prospective clinical trial, but then there were archived specimens and contrived specimen testing that was also done at these sites. So this is a lot of heavy, meaty stuff, a lot of charts, and I apologize for that. I'm going to try and just point out the key points. And the data is all in the package insert, which for any laboratory implementing this, I would highly suggest that you read that cover to cover, because it has a lot of very good explanations in it. Okay, so as far as limit of detection, for all of the bacteria, essentially you had anywhere from 100 to 1,000 colonies per CFU that are able to be detected in this assay. So as was already pointed out, E. coli K1 is the most common cause in neonatal gram-negative sepsis. Haemophilus influenza in babies who haven't been immunized, but actually we're seeing that quite commonly in the elderly population, sort of like we do with strep pneumo, sort of before vaccination, after vaccination of those two neaters of age, young and very old. Listeria monocytogenes, something that is not often positive on a gram stain. It's one of the bacterial causes that we don't see routinely on gram stain, although you will see a lot of polys. Neisseria meningitis, group B strep and strep pneumo, and Cryptococcus neoformans gattii. And as I said, 100 to 1,000 CFU ml or cells per ml for all bacteria and yeast. As far as viral detection, the 95% detection limit here, you do sort of a different measurement because obviously we're not growing everything, but essentially 100 to 1,000 copies per ml is probably what most people would understand. But for CMV, a number of different enterovirus species, A through D, HSV 1 and 2, herpes human viral 6, human parechovirus, which actually is a key component missing from our current enterovirus sort of group. It's those two that you think of in young kids, especially in the summertime months, and then varicella zoster virus. So again, 100 to 1,000 copies per ml. So in the analytical reactivity, in other words, we want to look at how many different strains of these organisms. We don't want to just use one strain, but how many different strains were included. There were a number of different strains used for every single pathogen in order to assess that inclusivity of the assay. Importantly, only encapsulated strains of Neisseria meningitis and only K1 serotypes of E. coli. But for Haemophilus influenza, both non-typable and typable, which would include your type B strains. Let's see, anything else specific? Not really. Okay. So how about cross-reactivity? So one of the things that you're always concerned about is, will a high volume of something else, let's say any other bacteria, would that cause a problem when detecting other bacteria? And essentially, all that was found in looking at over 100 different isolates at very high concentration was the enterovirus might cross-react with various rhinovirus. Haemophilus influenza will cross-react with Haemophilus hemolyticus, and Cryptococcus neoformans with another Cryptococcus organism. But rhinovirus and Haemophilus hemolyticus are rarely isolated in CSF. Although I would caution that rhinovirus, enterovirus this past year when we had D68, and supposedly this year there's a very virulent rhinovirus out there right now, it wouldn't be unheard of because we actually did a study in neonates that they can become infected with rhinovirus very early in life. So we'll have to see. Maybe a cross-reactivity wouldn't be so bad with some rhinovirus. The real key issue here is detecting it again in a person who might be sick and assessing those symptoms. And to also avoid sample contamination, and I will talk about that in a little bit. The other Cryptococcus species has not been isolated from humans. Okay, so precision reproducibility, these are all the things that you do during FDA clinical trial that thank God that it gets done in a clinical trial and we don't have to do it like a lab-developed test in our lab, which really prevents most of us from bringing on any lab-developed tests. So we look at every analyte at 3 different levels, moderately positive, low positive, and negative. And you need to get expected results in greater than or equal to 95% of samples. So this testing occurred at 3 of the clinical sites, multiple runs on multiple days, on multiple increments, by multiple operators, with multiple pouch and reagent lots, and basically the required expected testing levels was achieved at all sites. So very reproducible. All right, so how was the clinical performance? The BioFire assay was performed in hospital labs, prospectively collected patient specimens. They were residual spinal fluid specimens, so we did not get informed consent from patients. And the doctor had to have ordered at least a bacterial culture, but they could have ordered other things. And unfortunately, in our case, where we had both adults and pediatrics, it did limit the adult population we were able to assess as part of this clinical trial. Why? Because in kids, the diagnosis tends to be more often enteroviral and a quick diagnosis, and you have spinal fluid left over. And bacterial, that uses a little bit. But in adults, if it wasn't enterovirus positive and HSV positive, the net got cast broader and broader, and because of clinical reasons, we had to use that spinal fluid. So I would say the one issue I had at our site was we couldn't enroll all the patients I really wanted to do this test on because we couldn't get a diagnosis from the initial test. We needed at least 1,500 tests to show that the performance was going to perform in the attended setting. The spinal fluids were collected via lumbar puncture, and what was required was 500 microliters of sample, 200 for the film array, and then 300 for the reference comparator methods that had to go back to BioFire. And the specimens could not be centrifuged, key point. Okay. You got one attempt to do your film array assay, and otherwise it went to BioFire. So for the comparator methods, for bacterial, it was all culture, and for the viruses and Cryptococcus, it was 2 PCR assays and sequencing. The basic demographics were split into different age groups, sex, status, whether a patient was ED, inpatient or outpatient. I don't know who gets an outpatient lumbar puncture, but people did get classified that way. That might be another term for an ED hold, which is what I'm assuming happened. So the results of the bacterial culture were logged, results of any other CSF testing ordered, the CSF chemistries, and uniquely, and this is something that's actually changing in how FDA clinical trials get set up, usually everything is de-identified, nothing gets matched up ever, but in a GI study and now in this meningitis study, positive patients were actually given, you were given the name, and then the investigator had to go back and actually do chart reviews, see what the final diagnosis was, and correlate some of the symptoms, because the comparator methods weren't always, there wasn't always a clear indication about what was going on, and when the ME panel found something, could we actually make a decision about whether it was clinically relevant or not? And so that was done, that took a lot of time, but that was done for every single positive patient. So there were 1,560 specimens collected. 35% of them had actually been frozen because the pouches weren't quite ready for us to use, and we didn't want to lose those patients if we could enroll them. The study was done between February to September, so missing a chunk of the year, but basically a good chunk given the regional variation. 11 US study sites, so a lot of sites were involved. All age groups were included, but 41% of the specimens, again, were in patients under 18. So again, that sort of lends to the initial diagnosis in kids is fairly easy. Most of them were hospitalized or in the ED. As I said earlier, 98.9% of specimens were successfully tested on the initial test. That's really critical, because when somebody's waiting for a result, it's really nice to be able to tell them 98.9% of the time you're going to get an answer back one way or the other. There were 11 instrument software errors, and there were 6 pouch control failures. I think I had like 5 of these in my lab because one of the techs doing it couldn't push the plunger quite the right way. So we fixed that problem. And this was the overall positivity of the specimens tested in the prospective study. We had 8.7% positives, 19.4% were in kids 2 months or less, but you can see there's actually a fair number of positives throughout the age groups tested. The main pathogens were viruses, 16% bacteria, 3% yeast. If you go back and look at your own data, you clearly will find not as many positives bacteria, certainly not as many positive yeast. So we're definitely finding more organisms with this assay. This is actually, kind of a complicated slide. I highlighted a couple of things for my benefit to remind you of. So we typically have these assays pretty rapidly in our settings, the EV and the HSV. What we don't have, and what was clearly shown out, and I can point out with cases later, are some of the other things that might be fairly common, like paroechovirus and strep pneumo, where we know you get a single dose of a beta-lactam, you're not going to grow that organism in your spinal fluid. You may see it in gram stain, but it lyses so quickly it very rarely grows. And that can be quite discerning to know exactly what you're looking at. So we saw a lot of strep pneumo, we saw a lot of EV, and a smattering of everything else. The key thing here is that we did not see some pathogens at all. So we didn't see listeria, we didn't see Neisseria meningitis, we didn't see group B strep. And essentially, I have 2 cases of listeria this week, so we may be having an outbreak. We had the biggest outbreak of Neisseria meningitis in the country in Providence, Rhode Island, 2 Februaries ago. So unfortunately, we didn't hit it just right there. But so those we did not see. But a lot of other ones, again, mostly viral, a lot of HHV6 and human paroechovirus. So those are things we wouldn't normally have seen. What about co-detections? We know that we have a lot of difficulty interpreting what does a multiplex assay mean when we've got 2, 3, 4 positive organisms in that multiplex assay, especially for GI and RVP. Well, in meningitis, you don't get co-detections. That's just rare. And actually what the FDA said is that if you detect 2 pathogens with this assay, you need to go back and retest because it's highly unlikely to see 2 different pathogens in spinal fluid. And so this did occur in 5 cases, or 0.3%. So again, FDA is recommending retesting specimens showing multiple detections. And again, when I look at our data at Rhode Island Hospital and Children's Hasbro Hospital, in 5 years, we didn't have 1 child positive for enterovirus that also had bacteria. So that's why I say to the physicians, dump the antibiotics if it's EV positive, okay? So, all right. So there were a couple of performance issues relative to the comparator for culture. For group B strep, there was 1 false negative and there was 1 false positive. We'll explain those. Probably the biggest concern was there were a number of false positives with strep pneumo. And how do we resolve those? Well, with the strep B that was missed, was FilmArray positive but culture negative. It didn't look like the patient actually had a spinal fluid infection. They got started on a lot of antibiotics at the time of the LP, not immunocompromised, gram-staining negative. The clinical diagnosis was unspecified sepsis. So in the FDA clinical trial, that particular sample was found to be inconclusive. In the next one where the culture was positive and the FilmArray was negative, again, the spinal fluid chemistries were not indicative of infection, no antibiotics at the time of LP, the patient was immunocompromised, gram-staining negative, the bacterial culture notes 1 colony recovered. So the clinical diagnosis was GBS culture from medical implant, and essentially extremely low level positive missed by FilmArray. So that would have been a true false positive. So of concern to me as the physician is you're getting this result, you're getting it in an hour. Now I'm going to tell the physician, okay, it's positive for X. And then I got to wait. And does it grow in culture? Does it fit the clinical picture? Am I going to be eating my hat tomorrow? Which happens a lot. And so in this case with strep pneumo, it's the one thing we do want to be able to find because we know it dies quickly, we know the gram stain might be higher to interpret, we know the patient may have gotten antibiotics. So 5 could be confirmed by method or chart review, but 7 could not be confirmed. Again, subjects did not have evidence of meningitis or encephalitis. Why are they getting a lumbar puncture? I don't know. But the cause of the false positive really could not be determined. So again, it comes back to what is the clinical picture? Does it settle down after maybe you've gotten a few tests? Maybe the patient had a seizure. Maybe they have another reason to have altered mental status. But bottom line is that you cannot use this test alone without conjunction of other medical ramifications. So laboratory precautions. You have to be very careful about where you're setting these tests up and making sure you're cleaning between. You can't set up this meningitis panel in the same hood where you're processing your sputums and your spinal fluids and everything else that could be contaminated. And I think that this is one of those things that kind of gets forgotten by some laboratories, especially if they're not used to doing molecular tests. And this is so easy to do that that might be one thing to forget about. And it's not just contamination in the lab, it actually could also be contamination at the site of collection. So don't forget that people are drooling on themselves and wiping themselves all over their body where they may actually have contamination of organisms on their skin. So a spinal fluid is collected using an aseptic technique, and you go through all these sterile processes, but again, remember, you're palpating that patient's back, trying to find those vertebrae where you can stick the needle between, and almost like a venipuncture, you're not always 100% clean. So you have to watch not just laboratory precautions, but also cautions during collection of the specimen. And again, results must be correlated with history and epidemiological information. So what about the virus performance summary? Again, everything was actually very highly correlated with both positive and negative % agreement. The main thing really was the human the human herpes 6 virus, which again I think ends up being a little bit because of latent infections. And so this is the comment that actually comes up with HHV6 or CMV. That comes up when you get this result on the assay. These viruses can exist in latent form that are reactivated during infection due to other pathogens that are not detected by FilmArray, so something like mycobacteria or HIV. These should be considered as the likely cause of meningitis and encephalitis only in the appropriate clinical settings. So again, I think this is going to be a difficult interpretation to make, especially in the patient population we'd like to know, is this truly significant or not? So your immunocompetent patient or compromised patient that's got HHV6 or CMV. Viral shedding into the spinal fluid also occurs in cases of zoster or shingles. As that great case that Christine showed, chances are that would be VZV positive, certainly. But it's not always the cause of CNS disease in some cases. So I think that's going to be difficult as well. This is the other piece that actually was quite confusing, and I know I had to go and look at 3 different patient charts related to this issue alone. We know when we're testing patients for cryptococcal meningitis that we may see the organism on gram stain. It ultimately never grows because patients can have dead organism for a long time in their system even when they're being appropriately treated. They also will have positive cryptococcal antigen forever, even when they're being treated appropriately. So I always tell physicians, do not follow the titer. Finish the treatment, see if they're asymptomatic, then if you want to follow up, follow up. But basically, there were some issues related to interpretation of the results with this because cryptococcal antigen would be positive, but the FilmArray would be negative. And so the bottom line is that low-level cryptococcal antigen titers can persist for extended periods of time following appropriate therapy and resolution of the infection. And we already know that we see this. So if it's de novo testing and the patient doesn't have a history of cryptococcal disease, which in these cases all these patients did and were being treated, then I think it actually would be incredibly helpful to have this because everyone thinks that people who have cryptococcal meningitis are HIV positive and have severe immunosuppression. We've had 3 cases in the last 2 months. All of them were simply patients that were taking steroids for rheumatoid arthritis. They were not HIV positive. So we see this disease not just in the severely immunocompromised patient population. Okay. So the prospective data, essentially, again, very good correlation and high sensitivity and specificity and % positive agreement and negative agreement. Archived and contrived study specimens likewise did very well. There were 210 confirmed archived specimens that were used, 235 contrived specimens, 50 or more for each analyte. They were used to supplement for the testing organisms not seen in the prospective study, or those in very small numbers. So again, the ones that we didn't see during clinical trial, like Ophthalmos influenza, Listeria, and Neisseria meningitis, performed very well. Strep pneumo in contrived and archived samples, again, performed very well, as did HSV 1 and 2, HHV6, and VZV, and the Cryptococcus. No issues on known culture-positive specimens. The contrived sample study, residual CSF specimens, negative for all ME panel analytes. They were co-spiked, and then there were 35 negative specimens, and then 50 specimens per analyte tested at least 6 different quantified isolates evaluated. And then these specimens were tested at the study sites. And there was 95% agreement and 99.5% negative agreement as well in these contrived specimens. So the summary of all these studies was that the FilmArray panel was sensitive in a limit of detection to 100 to 1,000 copies per ml or CFU per ml for organisms, and that the clinical study showed 95 to 100% percentage agreement for most analytes. There was limited cross-reactivity, and the clinical study showed greater than 99% negative percent agreement for all analytes. This testing was very reliable, highly reproducible, very robust, very few clinical errors. And so if it's simple to use and you get a simple answer and you get it all the time, then that's really very, very good. So would this test improve patient care? These slides actually were taken from Kevin Borzak, a lot of the table slides, and this is some of the ones that we had discussions about. But in this young patient population where we saw a lot of the positives, in this particular group, there were 148 patients, and this percentage of positive was a 10% increase with the FilmArray compared to conventional methods. Would an algorithmic approach work in this patient population? So you're looking at enterovirus first maybe before you go on to a full panel? Potentially, but it's taking 4 hours to get that first panel done at a minimum in most places to begin with. But right now, more of those clinical outcomes are being assessed. And so I think that that's really one of the things that we're waiting for, and we'd like to see at the time the trials are done on how all this is really going to be used clinically and what the benefits truly are going to be for outcomes. So these are just some cases that I had literally in the last 2 weeks. A 6-year-old boy, previous otitis media, treated with amoxicillin, 3 days later pushed off a slide and presented to the ER with a headache. This spinal fluid had no organisms, but many polys, and he had a decreased glucose. So that screams to us bacterial meningitis. 2 days later, his strep pneumo actually grew on plates, which was amazing because I didn't think we'd grow anything. But he was a classic probable strep pneumo secondary to his otitis media. This is now our second case this week. An 85-year-old man, chronic steroids for rheumatoid arthritis, presents confused. His gram stain was read originally as no organism seen, but it was loaded with polys. He had a glucose of 35. Again, screaming bacterial meningitis. The next plates, there was a slightly beta hemolytic colony on the plates, and the listeria was identified by Maldi. The tech went back and reviewed the gram stain, a different tech, and there were obvious gram-positive rods. I put the slide under the scope, boom, they were right at me. And this is, again, my biggest concern. You have a person who you're relying on to make that first interpretation, and they totally missed it. There were so many mistakes made by this particular person, not calling a resident, not calling me, not calling somebody to look at the slide, and it was on second shift, and there were people around. But the bottom line is we're missing positive gram stains, and people are not getting the right diagnosis. Why does it make a difference in listeria versus strep pneumo or gram negative? The way you treat listeria is a completely different antibiotic. It's not the one you would use in empiric coverage in this age group where you think, oh, strep pneumo is probably the most obvious choice. Another patient just yesterday, three-week-old with fever and vomiting. The spinal fluid was bloody. There were no chemistries because they didn't have enough fluid. Our gram stain had 3 polys in it, okay, so not impressive, but it was called gram-positive cocci. The physician assumed strep pneumo or maybe group B strep, started the baby on AMP and Gent. The next day, the gram stain was reviewed because we review all gram stains done on third shift because we miss a lot of them, and it was basically corrected as negative. In calling the physician, he said, oh, well, I'm not changing it now. I'm continuing the course of treatment for this baby. So again, the baby continued despite a corrected report. Again, another misread gram stain. So one of the things that I read somewhere, it's nothing that BioFire necessarily promotes, is could this technology potentially be used without a gram stain? Can we do this up front without having to rely on that technical component? I don't really want to go there yet, but having 3 mistakes this week, I'm ready to consider it. Okay, so the benefits of this assay: rapid, simple, major meningitis encephalitis pathogens, less than 0.3% dual infection, which has been an issue with other multiplex acids. It has room temp stability, 98.9% result on the initial run, which I love that, small volume. Even if the organism is dead, you can detect it. So what are the conundrums? Even if it's dead, you can detect it. Or if it's potentially reactivated. And so again, I think we're going to have to learn how to use this assay, but just like we do now with qualitative, quantitative assays for these viruses, if it's a transplant or an ICU patient, is it really real or is it just reactivated? And then the concern is that those strep pneumos that came up, is there a possibility of contamination at the collection site or the lab, and that we really need to be clear on that. So I want to thank Kevin Borzak, who helped with some of the slides and answering all my endless emails, because even though I was part of the clinical trial, we never got any of the data to actually review it until this week. And then these are all the sites that participated. So thank you very much.